especially in the introduction of the macrobiology. I hope that. And learn about some principal groups exerting antibacterial activity with their different mode of action in inhibiting the protein synthesis in the bacteria. Today, we're gonna review some groups of those agents that inhibit the protein synthesis, including the macrolides. Then we're gonna move to the aminoglycosides, tetracycline, and lastly, we're gonna discuss the new agent, which is the Tigecycline, which is one of the glycyl cyclase. Now, before we start with discussing the inhibition of the protein synthesis, let's take a view about the ribosome, the bacterial ribosome. So the bacterial ribosome is a protein that's nucleoproteins found expelled in the cytoplasm, where that's the place where the most of the protein synthesis is undertaken outside of the nucleus. Initially, from the nucleus, after copying the DNA to RNA, so that's messenger RNA will be expelled from the nucleus towards the cytoplasm. Over there, it will meet the ribosome. So the main function of the ribosome is the manufacture of the protein, where the messenger RNA will be inserted between the two subunits of the ribosome. The two subunits, actually, they are totally distinctive parts. They will join together before the start of the synthesis, before it accepts the messenger RNA. We have two subunits. The small one, we call it the 30 subunits, which is represented here by the yellow colored subunit, and the larger one, which is the 50 subunits. So in their binding, that means that the messenger RNA will be ready to be accepted by the ribosome. And the ribosome, actually, we are coming to that. It consists of RNA and additional protein, which make the structure of the ribosome. So the ribosome is not only fully protein, it is an RNA beside a protein that make the skeleton of the ribosome. And the whole translation process will be when the messenger RNA will be read or coded by the codon-anticodon process with the ribosomal RNA. So we have a terminology we call it, when they combine the 50 and the 30 subunit, they will compose what we call it the 70 subunit. It's not an 80, because that will refer to a sedimentation ratio. It's like something like how heaviness of the protein when it gets beamed in a fluoroscopy. Now, so it's important for you guys. Why it's important to know this introductory information is because at each subclass of the protein inhibitors, they might will be binding to the 30 subunits, some of them to the 50 subunits. Later on, I'm going to come to the next lecture. We're going to see some agents, they will bind both subunits. And that means that these agents will be more efficient in blocking the protein synthesis. Now, that's as I just elaborated a while ago, we can see that here the lighted color of the red or the blue constitute the ribosomal RNA, and the rest is the protein. It's not important for you to know this structure, but just to help you in digesting the information that's needed for you to move forward during this presentation. Now, that's the bacterial ribosome functionality now. So, that's the messenger RNA that's expelled from the nucleus with the bases. As soon as it reaches, initially the two subunits, as I said, will bind. Then the ribosome is formed. Then the messenger RNA will pass through a junction between the 50 subunits and the 30 subunits. The translation process will start with the A site over here, with the transfer RNA, which is this one, or that it will carry, each molecule will carry one amino acid. Then by reading the codons, it will be inserted over here at the A site and the P site. Then the messenger RNA will be read, and that with each reading of each codon, one amino acid will be fixed or attached to the rest of the peptide chain. Now, the protein synthesis, this is the manufacture way. We could classify it in 3 different steps. The initiation, what we mean by the initiation is the process of assembly of the ribosome, when we combine the subunits and some certain accessory protein needed for the functionality of the ribosome. Then the elongation process, which means that adding one amino acid to the other till we get a chain of a peptide, which is the protein needed for building the structure and other structure and the enzymes for the bacteria for its functionality. Then the termination. The termination means that's the cut of the peptide when the peptide is ready made, it's full now. So now it's the time to cut it from the ribosome and to be sent for a different path within the bacterial cell. So these are the process of the translation or the protein synthesis in the bacteria. So just simply that these are the important parts of when the ribosome is initiated. We need some source of energy that's added to the transfer RNA to be enabled to move from the A site to the B site and bring the amino acid and to be released. And some sort of initiation factor that help the binding of the ribosomal and the messenger RNA, the transfer RNA to the ribosome. So we need some accessory proteins. Now that's the elongation process, as I said. So it's it's adding some amino acids when by the move of the messenger RNA, the RNA and the codon that's read by the anticodon. Now, importantly, we have an important enzyme, which is we call the peptidyl transferase. This enzyme catalyzes the process of adding the amino acids to each other, to the peptide. Some of the agents that we're coming to discuss, they block this enzyme. So that means the chain will be halted at certain length and no more amino acid will be added. And hence that means the bacteria will be stopped growing. And that is the termination process. How generally, how the protein gets, the synthesis of protein stop. Actually with certain bases like the UAG and the UAA, for example, these are considered as a stop codon. That means that there is no cannot be read by a suitable transfer RNA that holds amino acid with it. So with this base, the transfer RNA will come, but we cannot be fitted to match this base. So another type of protein that we call it the stop protein will be fitted instead of the transfer RNA, and that will stop the process of building up the chain, and the chain will be terminated, and the previous synthesized peptide will be released. So that's what we call is the termination process of the protein synthesis. Any questions regarding the synthesis now of the protein here? So I hope that's be clear. So we could move forward to discuss the agent that block these steps of the protein synthesis in the bacteria. We'll start with the macrolides. So generally, overall, most of the protein synthesis are considered bacteriostatic. That means they will not kill the bacteria, but will stop the bacterial growth at certain step. However, some of that's not an absolute, because we're going to review some sort of groups of the antibiotics. They are bactericidal, though they exert their antibacterial activity by inhibition of the protein synthesis. The macrolides, chemically, they are a weak basis. So generally, that's mean alkaline substance they favor to be inserted within the cells. So this gave the advantage of this type of antibacterial to target some certain pathogens that the residue inside the cell. They invade the cells, and the formal antimicrobials actually, because they are shaded away from the site of action, like the beta lactams, for example, they act on the cell wall of the able to kill this bacteria. So some bacteria, types of bacteria, they reside inside the cell, and these agents, they are the most suitable agents among the other varieties to kill this type of bacteria, because, and that's all thanks for their chemical structure, which is favor or the basic, or there are in the serum of the blood, they appear as basics. Now, the prototype of the first antibiotic in this group, called erythromycin, it was discovered in the 1940s. So it's one of the old antibiotics available in our hands. The newer macrolides, we have azithromycin and clarithromycin. These agents, they have sort of better tolerance regards to the GI adverse effect that most of the patients receiving erythromycin, the most important or number one cause of stopping the treatment of erythromycin was the GI upset. It caused bad abdominal pain, nausea. So introducing these, the two newer agents, the azithromycin and clarithromycin, helped in overcoming this GI adverse effects caused by erythromycin. Besides both agents, they have an extended antibacterial spectrums that, so we're going to find some bacteria are covered by the azithromycin and clarithromycin, not covered by erythromycin. And they're more stable to gastric acidity. So that's mean that could help the clinician to give a patient an agent that could be given less frequently, because as soon as it will decompose slowly, more stable to the stomach, the gastric acidity. So that means you can give it less frequent. That would improve the compliance of the patient. All the macrolides, by the way, they are antimicrobials, but on the other hand, they exert some sort of gastrointestinal excitatory effect. So they mobilize the gut. So especially erythromycin has been used as an off-label in patients with paralyzed GI, like after surgery, and some patients might go to ileus, so they might use erythromycin to mobilize the gut. Because of their chemical structure, these agents are linked to QT wave prolongation on the ECG, and that's important adverse effect of these agents. Always you need to pay attention on the first on the patient situation, if the patient status has a sort of any cardiac disease, or other the patient receiving other medications that jointly, when macrolides added, could prolong the QT. Similar like patient nowadays, because we are booming with the COVID, that hydroxychloroquine, the most worrying adverse effect of the chloroquine is the QT wave prolongation. That all of you hearing about the cardiac adverse effects, all of it of hydroxychloroquine is related to the QT wave prolongation. That will mean some times will be turned to torsade points, and the patient might go to ventricular tachycardia. I want you to just bear in mind that the macrolides, they suffer a sort of deficit, and they're unable to cover the anaerobic bacteria overall. Therefore, generally, most of the macrolides, they're used as respiratory antibiotics. These agents, they reversibly bind with the P site of the ribosome at the 50 subunits, and that will inhibit the bacterial protein synthesis by inhibiting the peptidyl transferase. So here, there's no more amino acids will be joined together with the peptide chain, so we cannot release a full peptide chain. So if I could ask you, which type of, if we could just review we had a while ago the process of the protein synthesis, initiation, prolongation, and termination. So the macrolides fit which process of the three? Yes. So it's the elongation process. Yes, because the macrolide will inhibit the process of adding more amino acids. So yes, it inhibits the elongation process. The erythromycin spectrum of activity, most of these agents, they are targeting the gram-positive. By the way, in general, overall, when we look at the macrolides, we look at as an agent that they target the gram-positive bacteria. So they cover the Staphylococcus aureus. How many sessions of microbiology you had? Micro. I mean, how many lectures you had? 2 or 3? I mean, I believe you know now about the gram-positive and the gram-negative, right? Okay, that's good. So I have the Staphylococcus aureus and the coagulase negative Staphylococcus aureus. It's enough for you to know that they cover Staphylococcus aureus, and they cover the Streptococcus species, and some gram-negative bacteria like the Neisseria species, which are gram-negative cocci, and the Haemophilus influenza, which are gram-negative bacilli. Okay, so and besides, as you can see, there's no much of the gram-negative cover. So and you know that's the Haemophilus influenza is the bacilli that causes which type of infections usually? It's found in the respiratory. Yes, you cannot. It's very rare you can find Haemophilus influenza from its name. Influenza, that means mostly it's resembled the former viral influenza. And they assume that was initially what that was the cause of the former influenza, what we know as a viral. Now, all of these bacteria they are found in the oropharynx area and in the upper respiratory tract. So that's why what made the macrolides the favorite medications for the respiratory tract infections. Besides, they cover some of the atypical bacteria, which also they could infect the lungs, like of the Legionella, and the chlamydia doesn't infect the lungs, mostly in the GI and in the genitourinary tract. And Mycoplasma is a very difficult agent that bacteria that could infect immune suppressed patients. It's also considered as an atypical bacteria, which is covered by erythromycin. Now, regarding the pharmacokinetics, these agents, they penetrate well in different sites of action. And that made them good for management of lung infection, with the bronchium of the lung. Sometimes you need high level of antibacterial to penetrate them. The half-life of erythromycin is 1.4 hours. So that means it's very short-living agent in the blood. So you need to frequently administer erythromycin for a patient that's giving at least 4 times a day. The main route of excretion of erythromycin is biliary, so it's not. You shouldn't be bothered by a patient with renal impairment. You could full dose the patients when you're going to treat them with erythromycin. The most important adverse effect is the hepatotoxicity, because these agents, they are secreted in the bile, so they are more concentrated in the liver. So the overall characteristics of these agents that accumulate at certain organ, you might get a good action, but on the other hand, you might get the adverse effects. So hepatotoxicity among the important adverse effects that limit the use of the macrolides. And there's two proposed mechanisms of the toxicity in the liver, that whether if it's a release of nitrose alkanes, or just simply it's an allergic, causes some sort of allergic reaction in the liver. And that's because many of the observations that patients who develop hepatotoxicity with macrolides, they find high eosinophils count. As I said previously, erythromycin suffer really common GI adverse effects. It could reach up to 30%. 30% is really a significant percentage of patients who experience GI adverse effects with erythromycin. So again, it's used as respiratory tract, to treat respiratory tract infections in patients allergic to penicillin. So that's the main use of the overall general macrolides overall. The most favorite choice for clinicians to treat infections are one of the beta lactams, but if the patient is allergic, then the clinician might select one of the macrolides. The second macrolide released to the market was clarithromycin. The most distinctive feature of clarithromycin is its ability, it has intrinsic ability to eradicate Helicobacter pylori. Helicobacter pylori is what we call it the stomach bacteria. It could live in the high acidic environment over there and cause peptic ulcer disease. And so after the whole treatment paradigm of treating ulcer was changed or shifted after we found that ulcer nowadays is an infectious disease in most of the occasions. So, and the infective pathogen behind this infection was Helicobacter pylori. So clarithromycin is one of the important antibiotics used to eradicate the Helicobacter pylori. You know that not treating Helicobacter pylori, by the way, in patients with gastric ulcer had a chance higher than other who don't have this bacteria to end with gastric cancer. So it's one of the risk factors for gastric cancer, the presence of Helicobacter pylori alone. As I just said a while ago, it has improved pharmacokinetic profile, so that's why it's given twice daily, unlike the erythromycin that need to be given more frequently to treat infections. Approximately 20 to 30% of the oral dose is secreted in the urine, so that will direct your attention that we need to adjust in patients with renal impairment. So in patients with renal impairment, you need to adjust the dose of clarithromycin, unlike the erythromycin. Another important characteristic, or that you need to know about the clarithromycin, it interacts with the P450 cytochrome enzymes, which is scattered in the GI and mostly in the liver. And many of the adverse effects, the drug-drug interactions of many medications, they are within the scope of the cytochrome enzymes. So if you have some medication that might induce the metabolism of other medications, some other agents would inhibit the metabolism of other medications, and all of these metabolism processes are mediated by the cytochrome enzymes. So among the important medications that could interact with clarithromycin are cyclosporin, one of the immunosuppressive agents, warfarin, one of the anticoagulants, and carbamazepine, which is an anti-epileptic agent. The clarithromycin is also more effective against the chlamydia species compared to erythromycin. The azithromycin is the most newest macrolide. It has some more advantages to the previous two macrolides. In regards of the gram-positive activity, the azithromycin is similar to erythromycin and clarithromycin. However, the improved activity of the azithromycin will be targeting the enteric bacteria. So now we can azithromycin cover E. coli, Salmonella, and Shigella. So these agents, that's the most important gastrointestinal pathogens that could infect the gut. Besides, when it comes to the Haemophilus influenza, azithromycin has 4 times more efficient in eradicating the Haemophilus influenza and the Moxarella catarrhal, which are known respiratory tract infection pathogens. The improved pharmacokinetic profile, now we have erythromycin given 4 times a day, clarithromycin given twice daily. Now, azithromycin could be given even once daily. And some type of infections, it could be given as only 1 single dose. So this is a really huge evolutionary step in the marketed macrolides. It has also one of the advantages is the least macrolide to interact through the cytochrome enzyme, the 3A4. And beside their ability to be used off-label, as I said, with the erythromycin as a gut motility agent, also it could be used as anti-inflammatory in patients with cystic fibrosis. This agent is hepatically eliminated, so that's mean there's no need to adjust in renal impaired patient. Patient with renal impairment could receive a full dose of azithromycin. However, you need to bear in mind that the use of azithromycin has been linked with more significantly higher rate of cardiovascular complications compared to the use of beta-lactams. The second group that among the protein inhibitors are the aminoglycosides are considered an old group of protein synthesis inhibitor. They are extracted from the streptomyces or the micromonospora, and that's where you can find some of them. They are the suffix MYCIN or the MICIN, depend on the source. This is an accessory information for you. For the coverage of the aminoglycosides, they're mostly gram-negative agents, more specifically against the Enterobacteriaceae and Pseudomonas species. So when we bring Pseudomonas on table, that means we are talking about a nasty bug that needs a strong antimicrobial. Unlike, for example, the macrolide, they have no activity against Pseudomonas at all. On the other hand, the aminoglycosides, they don't cover the gram-positive bacilli, and they don't cover the gram-negative cocci. Like what? We just had one of them, the gram-negative cocci. The Neisseria meningitidis, for example. Okay, the Neisseria species are considered gram-negative cocci. The Neisseria, okay? That will be sufficient for you if you know the Neisseria. Also, they don't cover the anaerobic bacteria, which is similar to the macrolides, but the mechanism behind here, why they don't cover the anaerobic bacteria, because they need oxygen to exert their activity, because they depend on the presence of electron provided by the oxygen usually, and when we talk about the anatomical level, to pass the cell wall of the bacteria to be internalized inside. It needs a transfer mechanism that depends on the presence of oxygen, which is not available in the anaerobic environment. So they devoid the anaerobic coverage. There's a conditional activity of the aminoglycosides against gram-positive cocci when they are only added to another agent like the beta-lactam. And we believe we had this the term. What is the term that when we discuss that in the principles of antimicrobials? That we call it the synergistic effect. Okay, the aminoglycosides will potentiate the beta-lactam for targeting the gram-positive cocci. If you recall that when we called it 1 + 1 = 3. So that would call the synergistic effect. Also, they could be combined with other anti-tuberculosis agents, like isoniazid, rifampicin, for the treatment of Mycobacterium tuberculosis. So they penetrate the bacterial cell wall through porine channels, and they enter the periplasmic space, and that depends on the presence of oxygen, as we just had in the previous slides. Then, when it reaches to the cytoplasm, it will bind to the small subunit of the ribosome, which is the 30S ribosomal unit, and it will inhibit the process of initiation. So it will halt the process from the beginning, unlike the macrolides. You're going to find with the macrolides, some proteins have already built, and it could be released, and it might exert some activity for the cell. Yet it's not full protein, but you can imagine if there's some sort of protein that might be included in some formation of enzymes and etc. But here with the aminoglycosides, there's one of the important aspects. It blocks the bacterial protein synthesis from the beginning. It also it exerts also another activity, and that's why we consider the aminoglycosides as bactericidal. They are among the protein synthesis inhibitor, but they are bactericidal. Why? Because, as I said earlier, that they inhibit the initiation process of the protein synthesis. And the other thing, now when it inhibits the apparent protein, and that will be inserted to the cell membrane, that will resemble or mimic the similar activity that we see with the beta-lactams. It will open pores in the cell membrane, so that will help the leakage of some important cellular material like the amino acids and etc. So that will kill the cell. So that's the distinctive features of the aminoglycosides, which make them bactericidal, though their primary mode of action is the inhibition of the protein synthesis. They are, again, this is a repetition of what we received the previous week. They are time-dependent, they are concentration-dependent antimicrobials. So that means the higher we achieve the level of the aminoglycosides compared to the MIC, if I achieve twice the MIC, I will get a level of killing. Then if I achieve 4 times of the MIC, I will get better killing than if I achieved only twice the MICs. The higher I get the peak of the aminoglycoside level in the blood serum, I will get the better the killing. This is unlike with the beta-lactam, which are time-dependent antimicrobials. Another important feature of the aminoglycoside is their ability to exert what we call it a post-antibiotic effect. That means when you detect the level in the serum of the blood or in the media or the blood, whether it be in vivo or in vitro, the level will be very low to inhibit the bacteria. It will be lower than MIC. However, at that point, the bacteria will not multiply. The bacteria will be in stationary phase. There's many theories behind this phenomena, whether if it's that the bacteria need a time to eliminate the aminoglycosides from inside the cell, so it will start to multiply. Other theory favors other theory that the bacteria will be in a process of shock and will stop copying the DNA inside the nucleus, as it senses there is something invading outside the environment, so it will stop copying the DNA. Again, they also exert the synergistic effect, especially with beta-lactams. And the theory behind that the beta-lactams will open more larger pores in the cell walls, so there's more aminoglycoside that depend on oxygen to be transported. So it will be far easier for aminoglycoside to be heading immediately to the cytoplasm and exert its action. Besides, that will inhibit the rate of the mutation and developing of resistance. Further.
I didn't understand the antibiotic.
The post-antibiotic effect. Okay, the post-antibiotic effect, that means usually the bacteria will not multiply in the presence of a detectable antibiotic. You need some antibiotic to be in the media around the bacteria to exert an effect. You can see inhibition of the bacteria. Now with the aminoglycosides, and you're going to see it also if you, I don't know if you had it with imipenem, one of the carbapenems, those agents, even if you detect a level in the serum, in the blood, you're not going to find any aminoglycoside in the blood. It will be very, very low. It's almost eliminated by the kidney or when it comes to the aminoglycoside. But at that level, the bacteria will say it's not multiplying. So the theory behind that maybe the bacteria will be in a process of shock, or even it needs time to eliminate the aminoglycosides from inside the cell till you regain stability.
So it will be dormant.
Okay, dormant is different phase, but yes, it has the same concept. Yes, in general, yes. Okay, which is one of the advantages that help in dosing the aminoglycoside as once daily, because I know if I need to repeat it, if I know that the bacteria will not multiply in the absence of the antimicrobial. So we hit by a large dose to achieve a very high concentration, knowing that these agents are concentration dependent, then regardless for the whole day how the level will be. These agents, they are not absorbed orally, and usually they use intravenously, but not always. Sometimes we use Erythromycin oral. Just we know it's not absorbed, so we get the advantage of this not absorbed medication to clear any bacteria in the lumen of the gastrointestinal tract. Especially in patients like in hepatoencephalopathy, if you have a patient with cirrhosis, those patients go in semi-coma, and one of the underlying causes of this coma is the bacteria in the gut will form sort of urea that will be absorbed in the GI and go to the brain and induce coma. So we might use the Erythromycin to cleanse the bowel or to clean the bowel from the bacteria that form the urea. These agents, they are renally eliminated, and they are get focused in the kidneys. So you suspect that these agents will provoke sort of renal adverse effects. They're water, that's why, because why they're renal, because they're water soluble. So you suspect, if you know that's an agent that any chemicals that water soluble, that means they favor their excretion by the kidneys. These agents, they don't penetrate well to the CSF. And because of their adverse effects, what we're coming to discuss, the ototoxicity and nephrotoxicity, these agents, we apply TDM, therapeutic drug monitoring. And the aim is to maintain the aminoglycoside at a certain level, that above that level, it will be turned to be toxic. So we could lower the dose and to assure that the level is high enough to eradicate the bacteria. So that we will apply it as we received in the previous lecture, that's what we call TDM, therapeutic drug monitoring. So the ototoxicity is one of the real limited the use of aminoglycosides, by the way. It occurs in a rate of 2 to 3%. There's many theories behind that, but generally we have two different entities of the ototoxicity. We have the cochlear ototoxicity, that will affect the hearing, and we have the vestibular ototoxicity that will affect the balance of the human. So the aminoglycosides could affect both functions, the cochlear and the vestibular, and the rate of sometimes it could reach to full hearing loss. So that's why we need to monitor the levels of the aminoglycosides. I need to mention that, the ototoxicity is linked to a persistent high level of aminoglycosides. I mean, that's during the day. Let us say we have the level that we needed for gentamicin is 2 milligram per liter. And for the whole day, the level was 8 milligram per liter. That the patient will be prone to ototoxicity. It's unlike if a patient, for example, reached 12 milligram per liter for only 5 hours, then it declined to less than 2 milligram per liter, that the patient will not be at risk of ototoxicity. So it depends on a continuously high level of aminoglycosides during the day. That will induce ototoxicity. On the other hand, the nephrotoxicity is dependent on how high we reach in the level in the blood serum. So yes, you could argue with me, just we need higher level of aminoglycosides to kill the bacteria, and that we could pump the patient with high dose. But on the other hand, we are killing the bacteria, but we are buying some sort of nephrotoxicity. So it will be, the nephrotoxicity is more common than the ototoxicity. It could be reached up to 10% of the patients who use aminoglycoside will experience a sort of brain dysfunction. It's most of the time it's reversible by stopping the offending agent. And that will cause increase in the serum creatinine, nitrogen retention, and you can observe some casts in the urine. The use of aminoglycosides, because they are potent agents, we use it for urinary tract and hospital-acquired infection, whether it's pneumonia or UTI, and could be used in combination with the beta-lactams in a synergistic effect to treat endocarditis, with other agents for TB, and could be part of the regimens to treat brucellosis. Now, the third group in this lecture today are the tetracyclines. They are bacteriostatic, and they acquired this name from the different benzene rings that you can see. And I don't know if you had this during your organic chemistry courses, that the much we get a benzene ring, that will improve the lipophilicity of the compounds. And as a rule of thumb, that the agents, the lipophilic agents, or any chemicals with lipophilic characteristics, they are more prone to penetrate the body tissues. So from this, we could estimate that the tetracycline will distribute well in the different body tissues. It will achieve high levels in the tissues, even higher than the blood, which is hydrophilic environment. So these agents, because of these benzene rings, they prefer the hydrophobic environment. They are old group, by the way, but not frequently used these days in treatment, except for certain diseases that we're going to come and discuss. They are considered as a broad spectrum, and because their activity are away from any cell wall or cell membrane, so they are effective even against some sort of microorganism that differ in cell wall, like the Plasmodium. They are, though, as I said, their use has been limited, but they're still considered in the treatment of Vibrio cholera, and they could be used as a salvage agents in a patient who's suffering Helicobacter pylori, that those patients who didn't respond to the first-line treatment. They are also effective in treatment of chlamydia infections. It's not important to know that the species of the chlamydia. Just want to know they are effective in treatment of chlamydia. And also nowadays they're widely used in treatment of acne. And doxycycline, I believe, now is one of the famous medications that dermatologists use in management of different types of acne. The most important or frequently used tetracycline nowadays are the doxycycline and minocycline. As I said, because the important those agents, sorry, are available in oral and IV form, and not used frequently because the coming adverse effect. But let us review before we go to the adverse effect the site of action of the tetracycline. So they inhibit the elongation process, and they bind the small subunit of the ribosome, which is the 30 subunit. Specifically, they inhibit the amino acyl transfers RNA that at the ribosomal site, which is very adjacent to the A site. Now, these are the most important adverse effects of the tetracyclines. The photosensitivity is very, very common. Which use patients who are using doxycycline, and so some patients, they go to the dermatologist seeking treatment for acne, but they end with another problem of the skin, which is the photosensitivity. Also, they might cause sort of GI side effects. The diarrhea could be because of the irritation of the mucosa and the lumen. And some of these agents, again, especially doxycycline, can cause esophagitis. The toxic effect will be at the level of the liver, so they can induce liver toxicity, and that limited the use of tetracycline. Rarely, the tetracycline byproducts after their metabolism might cause blocking of the nephrons or the tubules and the nephrons in a form, what we call it as a Fanconi syndrome, which could be lethal adverse effect. So always you need to apply caution in using tetracycline. Never use it in patients with elevated liver enzymes. And when you need to instruct patients who are using the tetracycline to avoid the use of cheese, milk, so any diet that contain high level of calcium. These agents, they really like the calcium, and that cause their heavy attachment to the teeth. So they're contraindicated in pregnant females. They might cause irreversible staining of the tooth. It varies from yellow color to gray color. And so it's more likely if the mother receives the tetracycline after the 25th week of gestation. So we're talking about not the usual, the first trimester, but we are talking about the second trimester where the tooth start to form. Also, children, it should not be given to children aged less than 8 years old. And that's because of the kidney, which is responsible for secreting the tetracycline, it's not fully mature enough to secrete the byproducts of the tetracycline. And even though some adults with a fully functioning kidneys, they might experience this adverse effect. So that's why tetracyclines actually, they dropped from favor for use in clinical practice. That's the last slide will be for tigecycline. It's one of the new groups. This group was introduced to the market in less than 2 decades back. We call it the glycine cycline. They are a derivative of minocycline. So in reality, they are derivative of the tetracycline. So we could extrapolate many of the adverse effects of the tetracycline to tigecycline. The coverage of the tigecycline, it covers most of the Enterobacteriaceae group, even those resistant to other, resistant to many of the beta-lactams, including those releasing the extended spectrum beta-lactamases. Also, they cover the MRSA or the enterococci, the gram-positive, the resistant gram-positive cocci, vancomycin-resistant enterococci, and methicillin-resistant Staphylococcus aureus. However, they don't cover Pseudomonas aeruginosa, and the tigecycline is hepatically eliminated, so you could full dose the patient, even patient with hemodialysis, with full dose of tigecycline. However, for unknown reason, patients who received tigecycline in a patient with hospital-acquired pneumonia, they found to die compared to other comparators. So that's why it's a black box by the FDA and should not be used in empirical therapy. Empirical therapy, that means we don't have a culture in our hand showing that this agent is sensitive. So we only use it if we have a confirmed grown bacteria in a media showing the sensitivity of tigecycline, but there's no other alternative available in our hands. Thank you very much. So for any question? Okay, thank you very much.
Dr. from the
Okay.
Okay. Someone was asking about what type of drug is hydroxychloroquine.
No, hydroxychloroquine is anti-malarial. It's not an antibiotic by all.
Doctor, are all the macrolides cytochrome? Are all macrolides?
Yes, all of them. Yes. But the azithromycin is the least. It's the least, yeah. Yes, Hakeem. Hakeem, hello? Hello? What's up?